Is my screen visible, sir?
Yes.
Yes.
Visible and
Yes,
audible.
sir. Yes, sir. One. Yes. So thank you, sir. Thank you for the kind introduction. And the first part of today's session will be to answer how to approach a child with motor delay. I'll just be talking about a very pragmatic approach that we can easily do in our OPD. So as we all know, motor developmental delay means delay in gross or fine motor domain or both. There are 5 domains of development. Conventionally, we teach as 4: gross motor, fine motor, language, and social. But for definition's sake, global development delay, there are 5 domains under which we have to evaluate. First is the motor domain, second is the language domain, third is the cognitive domain, fourth is the social personal domain, and fifth is the activities of daily living. So if there is significant delay, which is at least 2 standard deviations below mean on a standardized test on motor domain, we label it as global development. We label it as motor delay. And when the developmental delay could be due to psychosocial deprivation, we do not label, we provide stimulation and reassess after 6 to 9 months. And to start with, first, how to identify developmental delay. Some key red flags now I have enlisted here. If a child is not holding head steady by 4 months of age, if a child is not able to get up and sit by herself by 9 months of age, if a child is not pulling to stand and walking with support by 1 year of age, or if a child is not walking without support by 18 months of age, not running by 2 years of age, not jumping off the ground by 2.5 years of age, and not able to hop on 1 feet by 5 years of age. If any of these features are identified, we should suspect a delay in motor domain. These are definite red flags. Please understand, in a child with prematurity, child who is preterm, you have to use prematurity correction only until 2 years of age. Usually by 2 years of age, they catch up with a term child. So beyond that, a prematurity correction is not necessary. And for corrected gestational age, if a preterm child is lagging behind, meaning 6 months of age, prematurity correction of 2 months, child is now 4 months corrected gestational age, not holding neck steady, is a definite red flag. So with the corrected gestational age, we have to see the same milestone. And regression of milestones at any point of time is also a definite red flag. So these are some red flags which we should be worried whenever we are evaluating a child with motor delay. What are the more common causes of the motor development delay? The most common causes is any brain injury, a high-risk infant, preterm, IUGR, HIE, neonatal jaundice, or child has had any meningoencephalitis in the early year, which are likely to lead on to cerebral palsy. This remains the most common cause of motor delay in our setup in our country. Or the motor delay could be a part of a global development delay. The first manifestation would be a motor delay. So the motor delay will be a part of a global delay. Systemic causes like untreated congenital hypothyroidism, chronic infections, chronic renal ailments like a child with renal tubular acidosis, chronic cardiac problem like a child with congenital heart disease which is not well corrected. All these also could lead on to motor development delay. Nutritional deficiencies like a child with a severe acute malnutrition, a failure to thrive, vitamin D deficiency, rickets, or isolated vitamin D deficiency, and vitamin B12 deficiency, all those could result in motor delay. Neuromuscular problems like a child with spinal muscular atrophy, myopathy, or orthopedic causes like a developmental dysplasia of hip or joint hyperlaxity, benign joint hypermobility syndromes like Ehlers-Danlos, all those can present as motor delay. Now, how do we evaluate? As in any child with development delay, we start with a good history because antenatal, perinatal, and postnatal risk factors form the most important risk factors for motor delay. Most of the causes can be identified by a very good history. Document major milestones, rule out regression, and on clinical examination, look for any major or minor dysmorphisms and do a good neurological examination. The tone during neurological examination would form the key for further assessment. Now, how do we clinically approach? I'm just going to give one pragmatic approach. What do we do? A child with identified motor delay, do a clinical examination, tone. If the child has increased tone, hypertonia, we take the hypertonia pathway. If the child has normal or a low tone, we go for the hypotonia pathway. Now, what do we do if the child has identified hypertonia? We take the hypertonia pathway. you do a detailed history and examination. If it is a static illness and if the child has perinatal risk factors, and likely this child has cerebral palsy. Where possible, a confirmatory neuroimaging can be done. Otherwise, CP is a clinical diagnosis. If the child has no clues to etiology, then if the child has a dysmorphic state, we go ahead and do for a genetic evaluation where necessary. And if the child has micro or macrocephaly or with associated epilepsy, then we do an MRI and proceed further based on MRI finding. A child with hypertonia, after detailed history and examination, you notice that there is regression of skills. That is, child is worsening over time. Definitely, this child may need further evaluation. If it is a secondary or a tertiary care center, you initiate a neurometabolic evaluation. You also look for genetic causes like leukoencephalopathies. But at a primary care level, we can refer to a higher center for further evaluation. So this is hypertonia pathway, static illness or a progressive illness. Static illness with identified risk factors, start treatment, confirmatory neuroimaging where possible. Now, if the child has low tone or a normal tone, then possibly it's a child with hypotonia. And hypotonia we further classify as a child who is floppy strong or a child who is floppy weak. What is floppy weak? The child's power also is diminished. These children are usually socio-cognitively alert, but they have selective motor delay and their head circumference is usually normal. And their anti-gravity muscles will be weak, meaning neck control itself will be very delayed, and lifting the hands and legs against gravity itself will be very limited for these children. That's why we label them as floppy weak. So children who are floppy weak are likely to have neuromuscular causes of hypotonia resulting in motor delay. And the usual neurological finding is DTRs will be diminished or just elicitable. In these children, you do a CPK for muscle enzyme you do and do a EMG and a nerve conduction test. And based on this, you can differentiate whether it is a neuroaxonopathy or it is a muscle involvement. Now, a child who is floppy strong, meaning the child's power is okay, anti-gravity movements are okay. These children are usually due to central causes. The CNS is the most common reason. Now, they may have associated global development delay. Usually, they'll have microcephaly. There'll be associated epilepsy in a predominant number of them. The muscle strength is okay. That's why they're labeled as floppy strong. The deep tendon reflexes in them during neurological examination is brisk, and often you may also elicit a clonus. So DTR's brisk, muscle strength normal, hypotonia. So that is central hypotonia. The more commoner causes of central hypotonia are dysmorphisms or structural brain malformation. So this is a simple approach to how do you evaluate a child with a motor delay. Now, when do we do MRI in such children? When the child has perinatal risk factors and the child has static encephalopathy and the child has motor impairments and associated hypertonia or dystonia also. So child has disorder of movement and posture which is static due to an injury to the developing brain. That is the clinical diagnosis of CP. That's the clinical definition of CP. CP is a clinical diagnosis. Imaging correlation is not needed. But with the advent of MRI and with the availability of MRI, if an MRI can be done, an imaging correlation when possible will be very helpful. So that is CP, perinatal risk factors, static nature, neuromotor impairment. But when you have taken an extensive history, you're evaluated, but there is no clues to etiology, then all global developmental delay is not CP. In these children, you have to be very careful because they may have further etiology. You may need to search for further etiology. So when there are no identified clues in the history, in the antenatal or perinatal history, definitely a further MRI should be considered. A plain MRI is usually sufficient, but in conditions where we suspected mitochondrial disorders or a condition called cerebral creatine deficiency syndrome, it's one of a neurometabolic condition where the serum creatinine will be very low. So the global development delay with or without behavioral problem with associated seizures, no perinatal risk factors, and serum creatinine when you do as a part of routine blood work. If the serum creatinine is very low, which is inappropriately low for the level of the child's muscle mass or for the child's age, you should suspect this condition called cerebral creatine deficiency syndrome. And in such cases, you have to do a magnetic resonance spectroscopy, proton magnetic resonance spectroscopy. So identify patterns in mitochondrial disorders. There'll be an elevated lactate peak. In cerebral creatine deficiency syndrome, there'll be an absent or a very low creatine peak. So, in a child with unexplained motor developmental delay or a global development delay, if the child has associated micro or macrocephaly, if the child has associated epilepsy, and if the child has associated abnormal neurological finding, an MRI is definitely likely to pick up an yield. But if the child has normal head size, no epilepsy, normal neurological finding, then the contribution for MRI to the diagnosis will be very minimal. So do an MRI if there are associated neurological features, epilepsy or micro or macrocephaly, so that you will get better yield. And as we already reiterated, not all global development delay is a CP. You have to suspect disorders that can mimic CP in some conditions where no correlation between the history and examination. Many a time, child having slightly delayed cry at birth. Often, when we ask history, vehemently when we ask the history, அம்மா குழந்தை பிறந்த உடனே அழுதுச்சாமா இல்லையா அப்படின்னு போது mothers think that ஐயோ டாக்டர் இவ்வளோ தூரம் கேட்கிறாரு அப்படின்னு ஆமா சார் கொஞ்சம் லேட்டா அழுதுருச்சு like that ஒப்புதல் வாக்குமூலம் மாதிரி they'll give. So many a times that does not count as hypoxic ischemic encephalopathy. See, only the history of not having cried at birth is not enough. There should be documented features of encephalopathy. What is this? Seizures on day one, poor feeding on day one, having had extensive resuscitation and then following up with a nursery care for 1 or 2 days. Child being ventilated, being very sick, has had shock. All those are features of encephalopathy. Just history of not having cried at birth should not prompt you to make a diagnosis of cerebral palsy. You should document encephalopathy features by history. So when there is no history between the clinical picture, the history of the patient and the radiological picture, it is always worthwhile going ahead and investigating. How do you investigate further? Retake history, re-examine, neurometabolic and genetic evaluation. Do not go by the referral notes or previous notes of a known case of CP. Please re-evaluate again. And bladder and bowel involvement if it is present, or if the child has associated torticollis with associated short neck, or if the child has on spinal examination an atypical sacral dimple, a mass in the spine, or a tuft of hair in the spine, with a bilateral lower limb predominant involvement presenting like spastic diplegia, you should always think of spinal malformations which can mimic CP. And sometimes very slow progression can be there and which can be easily mistaken for CP in the early days. So if progressive spasticity, progressive difficulty in the child's walking, although suspect genetic causes like leukoencephalopathies. Many neurogenetic and neurometabolic disorders can mimic CP. For example, hereditary spastic paraplegia and arginase deficiency can mimic spastic diplegia. Glutaric aciduria and dopa-responsive dystonia can present like a dyskinetic cerebral palsy. And ataxia telangiectasia, mitochondrial disorders, Angelman syndrome can present like a predominant ataxic form of cerebral palsy. So all these are some of the examples of some common disorders which can present as CP and can be mistaken for CP. So when do we suspect a neurometabolic etiology? Because these are potentially treatable disorders which can present as cerebral palsy. If there is a family history of development delay, elder siblings affected, cousins affected, multiple family members affected, previous unexplained sibling deaths in parents, all those definitely you have to suspect, especially if there is a setting of consanguinity. That is one of the strongest points to rule out neurometabolic disorder. If the child has had recurrent episodes of encephalopathy, vomiting, child becomes very sick even with a minor illness, all those you should suspect a neurometabolic etiology like organic acidemias or a mitochondrial lactic acidosis like illness. If the child has severe hypotonia, severe behavior problems that is unexplained like psychosis like features at a young age, associated movement disorders like dyskinetic movements which are unexplained, and involvement of eye, ear, and muscle, multiple organ involvement if it is present, cardiac involvement, cardiomyopathy that is associated, liver enzyme elevation that is associated, all these should make us suspect a neurometabolic etiology. And obviously, when the child has coarse facies with organomegaly, you should suspect lysosomal storage disorder. So what is some basic neurometabolic evaluation which we can do? Availability of these tests are now commonplace. We can easily send even from a primary setup. So we go by the treatable ID evaluation protocol where at least the tier 1, some of the tier 1 investigations will do. Just doing ammonia, Lactate, urine organic acid, serum amino acid, acyl carnitine profile, and serum homocysteine profile will be enough. Remember, doing the neonatal screening using the dried blood spot may not be ideal because the standards that are given there are for neonates. The metabolite levels that are given there are for neonates. It may not be ideal for older children. So do not go only by the tandem mass spectroscopy of dried blood spot. Rather, you can ask for ammonia, lactate, urine organic acid, serum amino acid, where possible, a serum acyl carnitine profile and serum homocysteine levels, because many common immediately remediable metabolic disorders can be picked up just by these investigations. And when do you do a genetic testing? If the child fits into a particular microdeletion phenotype, like a child with a DJOT syndrome, all those, we ask for FISH, or conventional karyotype if it is a aneuploidy condition like Down syndrome. But when you suspect a child having unexplained global development delay with a dysmorphism that is not fitting into a particular gestalt, we usually order for a chromosomal microarray. When the child has unexplained global development delay, but no obvious dysmorphisms, but child has associated epilepsy and possible monogenic disorder, there is family history of similar illness, all those, then you go for a exome sequencing, because what test to order is also important. For example, a child with suspected Fragile syndrome, it is due to trinucleotide repeats, which can be picked up only on PCR-based tests. You cannot order a chromosomal microarray or an exome testing for this exome sequencing for this child. So what test you're asking should be dependent on what you're targeting, what is the suspected condition that you're evaluating for. Thank you.
Yes, Dr. Palaniraman.
Yes, we can go for the second lecture. Thanks, Raghav, for the precise and very brief lecture. When we'll take the questions in the development delay, everything afterwards, after the thing.
Okay. Thank you. So I might have to put my video off in between because the Wi-Fi is a little bit stable when I'm sharing the slide.
Okay, madam. No problem.
In case, yeah. Let me just share. You can see the slides?
Yes, ma'am.
Yes, madam.
Okay. So, good evening, friends. Absolute pleasure to connect with you all over this webinar. And I really thank the Tamil Nadu State Chapter, as well as Dr. Palaniraman for connecting with me and giving me this opportunity. So I was asked by Dr. Palaniraman to talk about my child is not speaking. But I'm going to go a little bit ahead and talk about not just speech delay, but more importantly, a bit of a broad topic, communication delay or communication concerns, of which speech delay is just a small part. So, so when we talk about communications, let us quickly go through these developmental terms. I think most of us might be quite aware about these terms of speech, language, and communication, but they are all very different. Speech is only what is coming through our mouths. It may be meaningful. These are the words which are coming out of our mouths. They may be meaningful or they may be non-meaningful and repetitive. And the various speech disorders can be articulation problems or fluency problems. Language is a lot more. Language has to have meaning. Language has to have grammar. Language has two parts. One is understanding of what somebody is saying to me, which is receptive language, processing the whole thing, and then expressing our views or answer through a set of grammar rules. So this is a verbal way, or language is a verbal way in which we communicate. The problems with language might be with its grammar, it might be with the use, how we use it. So we call it the semantics and pragmatics of language. When we come to communication, communication is a lot more than just speech and language. Communication is not only verbal communication, that is through language, but we communicate non-verbally. And when we talk about non-verbal communication, we are understanding what somebody is telling us. So that is non-verbal receptive communication, and then might be expressing it non-verbally through gestures or pointing or facial expressions or body language. So speech, language, communication are three different parts of development. So I'm going to just talk about these 4 points. When we talk about communication concerns, how do they commonly present? 1, how do we pick them up early? What can we do in the OPD? And last but not the least, what should we not be doing in the OPD? Okay, let's come back to this most common clinical scenario which I have been asked to talk about. This is a 2-year-old boy. No high risk factors, nothing in the history, birth, everything was normal. And he has come to you for concerns of upper respiratory infection or viral fever or something like that. And then once you've done that, while the parents are leaving, and this usually we call it as the doorknob, doorknob questions, where parents have come for a particular infection or something, and just while they are leaving, they are just mentioning that their child is not speaking yet. And what they want at this stage is some reassurance from you that all is going to be well. And our response here is going to be the game changer. Because what the parents are hoping that you are going to say, oh, don't worry about it, he looks okay. Your elder child also spoke late, so he'll also speak up. You know, boys speak later than girls. What they're also hoping, you will say, you know, you are using too many languages, or they feel the child is only 2 years of age, let's wait till 3 years of age. Or more commonly, they might want you to prescribe some brain tonic to accelerate his speech development. And this is what we are not going to do. Because once you've said this, parents are going to go back thinking all is well. And for the next 6 months, they are not going to worry about the child's speech at all. Because what we are trying to see here is the parents' concern, though, is it about speech delay here? Is it only this expressive speech delay which is present in the child? Or is there more to this, language and communication? So I've just made this quick list here of communication, and this is not a comprehensive list of development, communication development points, but something which we can quickly do in the OPD. So when we talk about communication, as we said, it's verbal communication through language, understanding the receptive and expressive, and non-verbal communication, understanding somebody's gestures, facial expressions, and expressing it non-verbally. So there are these 4 components to communication. Now let's just look at these non-verbal communication. So a child actually starts communicating his needs soon after birth. So before all this verbal communication starts, there's a lot of this non-verbal communication which is going on in the first 6 to 9 months of age. Soon after birth, the child cries when he's hungry or tired. When the mother is talking to him, he starts turning to sounds. He watches his mother intently. He shows interest in face. When the mother talks to him, he begins understanding facial expressions. Here, this one. And then might responsively smile. So that is all expressive, non-verbal expression of the child. When mother makes funny faces, he understands that, and then he might chuckle. And that's again an expression, non-verbally, or a verbal expression. He stretches his arm out to be picked up. He might, as he grows a little bit older, he will understand that mother is, waving by, and then he might start waving by himself. This is all non-verbal which is going on in the first 6 to 9 months of age. He starts looking at the mother's pointed finger and then looking back and forth with that object and the mother's eyes. And this is what we call as the joint attention. This is around 8 to 10 months of age. That is understanding the mother's non-verbal communication. And then gradually he himself starts pointing for his needs. And then later on to share his interest, that is his non-verbal expression here. So there's a lot of this non-verbal communication happening. Parallelly, there is an understanding of this verbal communication which is happening. He starts understanding no. He starts understanding that when they call his name, he has to respond with a head turn. He starts understanding the names of people around him. When somebody asks, where's mama, where's papa, he starts looking at them. Where's the fan? He looks at the objects or he points at the object. He's gradually, by around 15 to 18 months, he understands the names of body parts. And by 18 months, is beginning to follow some simple commands. Parallelly again, his vocabulary is increasing. By 10 months, the child is babbling. By 1 year, we expect at least one meaningful word where the child is saying bye or mama or de do or give for his needs. And then as the child is growing older, many meaningful words start and the child starts forming sentences. So by 2 years of age, 2-word joining starts, and by 3 years, 3-word sentences should start. Now, when we talk about this verbal communication, it has to be meaningful. So only repetition is not what we call as communication. Repetitive just speech is not communication. Along with this communication in children, all of us, we are looking at what is called as social communication, the interaction and the play skills. So quickly, when a parent is asking you on this doorknob, whether the child, they have to be worried about the child's speech, we can quickly ask a few questions about how he communicates and how he understands when you try to communicate. So you can ask about, does he point? Does he not? He doesn't speak, but does he point or gesture? Does he understand when you ask to show objects? Does he follow simple commands? And what I've done here, I've put a few case scenarios here, and do feel free to chip in here. So this child with speech delay, if we ask more, let's take the scenario 1, where the parent says, you ask a few more questions about this communication, and the parent says, the child is not understanding what I'm saying, and the child is not speaking verbally, but non-verbally, the child is communicating extremely well. Any input from all of you? What is the first thing that we need to do?
Hearing.
Absolutely. Okay. So verbally, the child is poor in receptive and non-receptive, receptive and expressive, but non-verbal communication is very good. Let's take the second case scenario. Similar, receptive and expressive verbal communication is absent or poor or delayed. Non-verbal is present. We have done the hearing test, and that's normal. This, what we call it, mixed language disorder. So a disorder of receptive and expressive speech delay. Let's come to scenario 3, where the child is not speaking verbally or has a verbal, no meaningful words yet, but the parent is saying that non-verbally he's doing absolutely fine with gestures. Understanding of language is fine. So what is only remaining is the expressive speech delay. So the most common thing is the late bloomers, as we call them, the developmental speech delay, who will catch up. But we always have to remember verbal apraxia, a component of a diagnosis called verbal apraxia, where there's problems with coordination. Just like we have coordination of hand-eye coordination problems, verbal apraxia is problems with coordination of speech. Scenario 4, parent says no receptive, poor in receptive, poor in expressive, poor in non-verbal, poor in receptive. So communication delays are there. And there's delays in gross motor, fine motor, cognition, play skills. So this is
global developmental delay.
This is global developmental delay. Okay. Next case scenario. Delays in social communication, interaction, play, gross motor, fine motor, cognition, okay. Autism spectrum disorder.
Yes.
Let us be very clear that there can be, mixture as well. You might have autism spectrum with global delay as well, or you might have autism spectrum with apraxia as well. But this is something which I have put so that it is a quick assessment in those few minutes of OPD that you have. Okay. Every child, you're not going to be able to spend a lot of time. What you need to decide is this something which I need to take ahead, or is it something which I can reassure? And the last case scenario, so same child, the child is the same. The parent is saying speech delay. The child is here, the parent is saying he speaks extremely well at home, but when he goes to school or when he meets outsiders, new people, he's not going to open his mouth. He's completely mute. So we have to think about selective mutism. And the diagnosis usually is clinched when we get videos from home environment or an environment where the parent or the child is very comfortable. We ask for videos, we look at them, and then we know that the child's all these, we are not going to rely on the parents' history only. We are going to look through videos, whether this receptive, expressive is within normal limits or not. Okay, so these are some of the case scenarios with the same history of speech delay, but the diagnosis can be completely different. So speech delay is just a symptom, and we have to go a little bit more without just reassuring that all is well without asking things. So speech delay, the verbal expression, as we said, is the commonest presenting symptom, but it is a late symptom because as we saw in that chart, there's a whole lot of non-verbal communication. There's a whole lot of receptive language which has to develop before meaningful expressive communication develops. And parents are only going to talk about this verbal expression. By the time they realize that something is missing or something is delayed, it's about 2.5 to 3 years of age. So how do we pick up early? Because parents are not aware about the developmental milestone. Let's understand that any kind of communication to start, the basic senses have to be normal. So we should never, ever, ever forget about the hearing and the vision. If the child can't hear properly, the further things are not going to develop. If the child can't see properly, then the gesture and the facial expressions and the eye contact may be affected. So a universal newborn hearing screening, OAE, is, I think I don't need to stress how important it is. And high-risk babies, BERA is something which we are going to do. So there should be no compromise on these things. The parents are always going to come and tell you that, he can hear. I don't think, there's a hearing problem. And all that we need to do at that point is write it on paper that this is something which you have advised. At the same time, you can counsel the parent that, 99.99%, I'm sure he can hear. But I want to know it 100% because that is the only test which is going to change our entire treatment. Because I have come across many children, you can say, who have unilateral hearing loss. The child can hear some things, but the child is not attentive to all sounds. So just for my sake, get a hearing test done is what you can counsel. I know that it might be normal. So let us not forget about the hearing test. As we said, parents are never, they do not know the right kinds of, what is the right age for different developmental milestones. So it is our duty to have a robust developmental surveillance and a screening program. This is a chart I think you might have come across. This is something which I had made about 15 to 18 years back. And quite a few pediatricians, definitely in Navi Mumbai, have it. And across the country had asked for this. This is where we link it with immunization chart. And I'm aware that Tamil Nadu, the state has different cards as well. And this is quite similar to that. What I usually suggest is a lot of times parents or doctors are in a hurry and may not be able to look at the cards. If this is your immunization chart, if it's, put it on the file itself. If your file has one page which has this immunization chart along with your batch number and this, the last one should be a developmental surveillance thing. And I put 4 points for each immunization. And I know you can't see it very well here. I'll just try and zoom it. 1 minute. As you can see, for each immunization schedule, if we have one gross motor, one fine motor, one social, one speech, this is not comprehensive. So this is not screening, this is not assessment, this is just a surveillance thing. Our immunization, we see the child for around 7 to 8 times in 2 years, the first 2 years for immunization. If we just go through them, we are not going to miss out big things. Definitely, we are not going to miss out the big things. Let's look at this 9-month-old MMR, measles vaccine here. Sits with support, without support, whether the child is sitting without support, whether the child has attained assisted pincer, whether he's babbling, whether he's responding to name, he's beginning to peekaboo, he understands. So there's this non-verbal communication, there's this play, there is physical, and there's fine motor. Okay. If the parent says at that time, no, he's not sitting without support yet, that does not mean that necessarily there is a big problem there, but that certainly you can, circle it out and call the parent in a month's time and, give some counseling. We'll talk about that a bit later, and then call them to see whether the child has improved or not. So I think this is what, okay. So this is something which you can use, or you can use any developmental surveillance or screening program that you are used to, but definitely we need to make use of that. Third important thing nowadays is the autism screening test. Ideally, we should do it in every child at 18 months and 24 months. And definitely if there are concerns about communication. MChat, I think most of you will be familiar with, and there are translations in Tamil as well. I think the only thing which I would like to, bring to notice here in these 20 questions of MChat, not a single one talks about speech, expressive speech. So there is no question in this about how many words a child is speaking, which reiterates the, our what we say is that autism is not a speech problem. It's a communication problem. So all these questions are geared towards non-verbal gestures, receptive language, play skills, and social interaction. This is kind of one of the posters that we in Navi Mumbai had given it through our association to the pediatricians to be put in their waiting room, where some early symptoms of autism spectrum are written. So by 6 months, no big smiles or joyful expressions, no response when the child's name is called by 10 months. So there are some of these symptoms which the parent, when they're sitting in the your waiting area, might go through. And if they are concerned, they might talk to you about it. So this is all there, and you can put a similar chart in your OPD, which will make it easier for the parent to ask questions. What can we actually do in the OPD when a parent talks about speech delay? Anticipatory guidance in well baby visits. All children, we need to talk about anticipatory guidance. We talk about how to stimulate language, eye-to-eye contact, playing with the children, reading books, and definitely restricted access to screens. I think this mobile and screens, I think we need to come very heavily when we talk about it. In fact, the way I put it is, because parents will always, kind of say, oh, I only show it for 15 minutes. Oh, it's only for 5 minutes, not much more than 5 minutes, or not more than 10 minutes. And what I actually tell them is that it has been proven, worldwide that exposure to mobile will affect your, before 2 years of age, will affect your child's not only speech, it will affect the child's behavior, it will affect the child's attention. So according to me, it's actually poison for your child's brain development. And I use the word poison so that it's kind of, and whether you want to give half a spoon poison or 2 spoons poison, that's your, so when you say that I'm going to give 15 minutes of mobile for my 6-month-old or a 9-month-old, that's a choice that you are making. But do understand that this is not going to help your child's development. Another thing which I always say in my talks is, just like we write on our paper, on our files, breastfeeding is best for the child's health. Let us start writing in broad, red, bold letters what mobile screens do to our children's brains. So unless and until it is staring at them all the time, this warning, parents usually kind of we are just, and we have these guidelines to help us, the IAP guidelines for screen time. Second thing, very importantly, we are going to talk about parental counseling regarding communication difficulties. What parents are focused on is the speech, that is the verbal communication, but these children have many pre-speech deficits which we have to tackle before meaningful communication starts. And I cannot tell you how important this language pyramid is, where the interaction, the attention will when the parent between the parent and the child is needed for further development here. Play is one of the most important ways in which a child's communication and interaction develop, and we really need to talk about play in our OPDs. When you talk about play, when I ask what your child plays with, parents usually come up, oh, he plays with blocks, he plays with puzzles, he can put pegs in a board, but that's not play. Play is interactive play. Play is pretend play. Play is with an adult or a peer. So the repetitive activities which are nowadays being which are always put forward as play, we need to kind of counsel them about it. Simple things: establish eye contact, use dramatic facial expressions when you're talking to your child, use a lot of gestures, label the environment. When I say label, it means look at that, no, look at that door, look at that dog. So give label or give nouns or give names to objects in the surrounding. The child learns by imitation of activities and interactive play. And a lot of communication happens in the social play that happens in your daily caregiving activities. And very importantly, let us counsel them to stop teaching non-meaningful passive repetition. Just saying ABCDs and 1, 2, 3, 4s. My child can speak till 50, but my child is not able to call out mama. I think that is something which we need to counsel them about. Quickly, a few tips to parents. Speech delay can be a stage or a symptom. We need to refer and assess as needed depending on where the child's problems are. Discussing screen time always. The 4 S's that we talk about is use short, simple sentences. Stress the keywords. It might be a short sentence, but look at that dog. Okay, so stress the keywords. Speak slowly and use a lot of gestures and facial expressions to get the child looking at you and interacting with you. Last but not the least, what should we not be doing? As we said, reassure blindly, no, unless we know that things are happening, the other things are happening, and refer blindly. So blankly referring to a therapist with the wrong expectation of getting some speech out of the child's mouth is neither early nor right intervention. Because sometimes, again, they might go to a therapist, and if it is not the right therapist, they might end up having echolalia or repetitive speech, non-meaningful. So somebody who is just going to treat the symptom of speech by repetition, that would be a wrong outcome unless we have a good diagnosis. Thank you.
Wonderful, madam. That is the only word which we can say. President, sir, you can start the discussion, sir. Just on the basis of this topic, you can start with the discussion. Then we can progress with the discussion one by one. Yes. Because you are also basically a very good neurologist, so you can also start the thing as
Okay, I will start with Srinivas Raghavan. Would they commonly ask, எப்படி சார் முதல்ல கண்டுபிடிச்சிருக்க முடியாதா, குழந்தை பிறந்திருக்க முன்னாலே கண்டுபிடிச்சிருக்க முடியாதா இந்த மாதிரி questions, that's what they ask. Would have not been made out in utero or something like that. Is there anything to avoid or prevent these things, sir? கொஞ்சம் அட்வான்ஸ் கொஸ்டின் தான் இது.
Yes. So, ma'am wanted to answer.
No,
Ma'am
I
was-
didn't want
No,
to
no.
answer. I couldn't understand the question because it is in Tamil.
Tamil.
No,
Okay.
no, no. I saw is there any way of preventing this such childbirths? That's what they can ask.
Sure.
Yes.
And
Please carry on,
how
Dr. Srini.
far sure we will not get such a child later?
But neurodevelopmental disorders cannot be predicted a priori, sir, because only things that can be picked up prior by good antenatal scan and all those are a child with a proper genetic disorder, which previous sibling was affected and an antenatal diagnosis was done and the child was identified in utero, can definitely be picked up. Structural malformations of the brain can be picked up, whereas these things are not seen in the external structure of the brain. For example, a child with autism, the structural appearance of the brain may be okay, whereas the functioning only is affected. And as and when the child develops, when the child has to develop the age-appropriate milestones, when we notice a delay, only then we'll be able to identify. So knowing that this child would go on to develop a neurodevelopmental disorder a priori is not possible as on date, sir. So that would be the answer, sir. ஸோ முந்தையே நம்மளால வந்து இதை கண்டுபிடிச்சி சொல்றது இயலாது. ஏன்னா இந்நாள் வரைக்கும் இது வயிற்றுக்குள்ள இருக்கும்போது கண்டுபிடிக்கிறதுக்கான டெஸ்ட்டுகள் எதுவும் இந்நாளுக்கு அது அவைலபிள் இல்லை அப்படின்றது ஒரு எக்ஸ்பிளனேஷன் we can give for parents in Tamil, sir.
So actually, once you fix a diagnosis of delayed development, or first thing what you get in their face is the guilty feeling. Number two, whenever we ask a question whether it is a consanguineous marriage, immediately their morale becomes too low and they really feel very bad about it. They have done something wrong in their life and all. That is the thing which is actually pitiable situation there. Yeah, continue பண்ணுங்க பழனிராமன்.
Yes. Sivaraman. Yeah, you can start the discussion. Start, sir.
Okay, sir. First of all, thanks to IAP TNSC, President, sir, Secretary, and everyone. Thanks to Dr. Palniraman, sir. And excellent lecture by both the speakers, sir. Just going on to what we could share for a pediatrician with regard to Dr. Esa's lecture. One thing is the term, as a pediatrician, we should never use the term mental retardation. This is one thing. That term is out of vogue now. GDD below 5 years, above 5 years, intellectual disability. So the younger brother of intellectual disability is GTD. This is the first carry-on message for the pediatrician. Most of the time, we still see people writing as mental retardation. Second, sir has clearly told about the milestones. So I just want to stress on some of the things which have recently happened with the milestones, because the CDC, all of us, since sir was telling it, developmental pediatrics was a topic which was not given much importance. Even the CDC didn't give importance to it. 2004, the milestones were formed. After that, only in 2022, when COVID came, the CDC has woke up and revised the milestones. So what is the carry-on message for the pediatrician here is, previous to 2022, if I was telling a child is going to walk at 1 year, that means 50% of the children were walking at 1 year and 50% were not walking at 1 year. That is why the concept of wait and watch was there. Now the CDC has changed the guidelines. They have shifted all the milestones a little ahead. So walking, we take it as 1.5 years. So if a child, that means they have moved it to the 75th centile. So if a child doesn't do it at that centile, there is no question of wait and watch. So the second carry-on message I would like to give from that lecture was, there is no question of wait and watch. So please, as a pediatrician, we never tell wait, because that wait, so like we see a case, maybe the last case in the OPD, and the last question they will be asking, like madam told, was, he's not talking now. That wait, if I told that time wait, it may be for 1 year, it may be for 2 years, because the doctor has told wait, we do not know. So that wait and watch should not be there. Second, sir, that clearly told about floppy, strong and weak. That was a very good thing for a practitioner. When it comes to hypertonia, one carry-on message I would give is, these children have very early milestone achievements. So we call this aberrant milestones. like usually supine to prone will come before prone to supine. This is one of the things I would like to give a carry-on message here. And obviously the early hand preference and sitting with one side. So all these things can happen with hypotonia. CP, the biggest message we want to give now is, previously all the question was, did the child cry at birth? So definitely all the parents go and blame the obstetrician that your child, the question asked by the pediatrician was this, and we insist, we keep 2-3 times you're asking this. It has been clearly documented that most of the cases of cerebral palsy are, the causes etiology is intrauterine. Almost 70 to 80% is intrauterine causes. So another thing which I would like to just tell about regarding cerebral palsy, sir, we do MRI, but there is off late, there is one more entity, you can do a GM assessment. This is a general movement assessment. So just by observing the baby in the ICU, this is for the pediatrician. Just looking at the baby, most of the time we see children, newborns who have a poor repertoire with the cramp synchronized. These two are together. Almost it tells 98% sensitivity, this child may develop cerebral palsy. General movement is an upcoming thing regarding management, early identification of cerebral palsy. That is, even before an MRI, you can pick up a child with cerebral palsy using a general movement assessment. CP mimics, sir, just one more point I just wanted to add. Obviously, there are no risk factors. Whenever you see 2 children affected in the same family with cerebral palsy, definitely it is not cerebral palsy. Because I've had on occasion where 2 children, siblings, it's labeled as cerebral palsy. It cannot happen. 2 children in the same family cannot happen. And if it is progressive symptoms, it is not a cerebral palsy. It is a CP mimic. Fluctuating symptoms, it is a cerebral palsy mimic. So these are the things I would like to highlight with Dr. SR's things. You would like to comment on anything, sir, or no one else?
Srinivas Raghavan, for the practitioner's sake, 3 important questions. Isolated motor delay, treatable causes which are not to be missed, number 1. Number 2, essential investigation in isolated motor delay, number 2. And the CP mimic, treatable CP mimic, number 3. These are the 3 questions that is mainly we want for the practitioners.
Yes, sir. So in clinical practice, some of the conditions that we should never miss in a child with isolated motor delay is, first is again congenital hypothyroidism. In places where thyroid function tests are not done at birth, it is definitely worthwhile examining for hypothyroidism, because the sooner we start treatment, the better the outcomes of the child. Second is neuromuscular causes, like a child with a developmental dysplasia of hip. All those can present with isolated motor delay. So hip examination sometimes at birth can be missed. So if the hip examination was not done at birth, it is definitely looking at a local bony causes, which could result in isolated motor delay. Third, certain medical causes, nutritional causes, especially in families where there are a lot of food fads, or where the child is a very difficult eater, or appropriate complementary feeding has not been initiated. Child can have failure to thrive, vitamin D deficiency, vitamin B12 deficiency. These 3 can be immediately remedied and are very potentially treatable early causes for motor delays. So these are 3 causes that I would say, which could be easily ruled out by clinical examination and with a very specific blood investigation that can be done.
Also vision. Sometimes vision impairments can cause problems with motor, with walking.
And
that
3
question is coming to you next, madam.
Yes.
That question is coming to madam next.
Then 3 potentially treatable neurometabolic disorder that should not be missed is, as I said, there are a host of neurometabolic disorders. As of date, there are around 100, nearly 100 treatable intellectual disability protocol, it's called. There are around 100 neurometabolic disorders which are potentially treatable. But in our setup, we can group as organic acidemias, urea cycle defect, mitochondrial disorders, these 3. Among these 3, organic acidemias and mitochondrial disorders, those 2 can be picked up earlier because they can cause recurrent episodes, and each episode can be life-threatening. So those 2 should be definitely picked up. Urine organic acid, serum lactate, and MRI wherever possible, MR spectroscopy for a lactate peak. Some of these mitochondrial disorders are potentially remediable, especially if you give thiamine or other supplements, cofactors. When we supplement, these children can not have further episodes potentially. Organic acidemias, again, some of them elimination diets, branch chain amino acid restricted diet, all those when we give, or a child with a glutaric aciduria, where we give specific medications and also follow a special diet for them. Definitely further decompensation can be prevented. But definitely urea cycle disorder should be kept in mind, where further regression can be prevented, especially arginase deficiency, all those. Just by doing serum ammonia and plasma amino acids, and when these are elevated, doing a focused IEM panel, a genetic testing panel, may arrive at the diagnosis, and further decompensation and further regression can be prevented. So I would suggest urea cycle disorder screening, organic acidemias, and also mitochondrial disorders. Those three disorders we should definitely look for and identify early, because they are potentially treatable. And third question, sir. Sorry, sir.
CP versus CP mimics, treatable CP mimics. What are the treatable CP mimics?
Sir, sir, your mic is on. Sir, CP mimic.
What are the treatable CP mimics? Treatable CP mimics.
Yes, sir. Those are the neurometabolic disorders which we identify are the potentially treatable disorders that we have. Where we can, if identified early, can potentially be treated early on with restricted diets and cofactor supplementations. So, Panirama, sir, your mic is off.
Madam, apart from vitamin D, iron deficiency, B12 deficiency, or any other treatable thing which can cause isolated motor delay?
So one is vision I was talking about, because vision has to be kept in mind.
Okay.
Undernutrition, overnutrition, both can cause motor isolated motor delay.
Obesity also, yes.
Under and over, yeah, both.
Over. Okay. Visual and hearing handicaps, clues to detect early. Because we are insisting at all the levels, this is very important, visual and hearing handicaps, because in the periphery, OAE is out of question in the near future. It will take time for us to think of OAE and the thing. So what are the things, how you can say, by particularly visual and hearing handicaps, how we can pick up in a day-to-day practice?
So in day-to-day practice, sir, I mean, I think the hearing, the response to sounds, it should start all quite early. Head turn, those things. But we have to be very aware about the high-risk children. Once we are aware about the high-risk children and we are following them up, the surveillance, the developmental surveillance, every time when you meet the parent for the first time when you meet at 6 weeks, you can ask about, awareness of sound. Does the child have startle with sounds? It all starts from there. But these are all very crude tests. We really, I think OA is one of the most common and most easiest. So I think it really has to reach, if not better, OA has to reach every corner of our country. Very easy to do it as well. Even 12th grader can be trained to do an OAE. The machine costs 2 or 3 lakhs, and it can be shared with the pediatricians.
Oh. Raghav, this is another question, because we know by mainly the vision, anything particularly, if there is mainly searching nystagmus or any anterior compartment cataract or any anterior compartment problem, anything we can easily pick up. And sometimes we are not able to pick up anything, and particularly the ophthalmologists say the vision is perfectly reasonably normal. But still, people say, because when there is hypoglycemia, there can be functional visual problem. Yes. How can we pick up in the practice? Because that can be a cause for the development delay.
Yes, with the improved survival of preterms, with improved survival of VLBW infants, we have to be aware of an entity called cerebral visual impairment. So cerebral visual impairment is one of the key factors which can present with vision impairment despite a normal ophthalmological examination. So the preliminary ophthalmological examination, especially the anterior segment, the posterior segment, may be perfectly okay, but the child may still not be perceiving things. That's why it's called as brain blindness. In simple terms, to make parents understand, we call it as brain blindness. And there are two entities. One is a high functioning CVI, where the visual acuity is not actually much reduced. But there is also an entity, the low functioning CVI, where the visual acuity is reduced. So those children, they can present as global development delay because vision is required for motor functions, eye-hand coordination will be affected. And as ma'am said, the child will be sitting up on time, but after that mobility will be restricted because the child's vision is impaired. And child social function, communication functions can be impaired because child is not looking at anyone else. Child may have repetitive motor movements. Child may have a lot of stereotypies which mimic autism. So these children can often be mistaken for global development delay, can also be mistaken for autism. So how do we evaluate these children? If a child definitely has risk factors, identified perinatal risk factors, screening vision development is mandatory. So is this child looking at faces? Is the child able to reach out for objects? So most parents say that social smile will be delayed in many of these children. The child may be alert to mother's voice. Child may have a social smile to voices of mother. Somebody going and cuddling the child may actually be listening to them and smiling. But the child may not be looking at the mom and smiling often. So social smile will be for verbal responses, may not be there for the visual cues. Child may not be able to reach out for object. The child will search for object, and once the object is placed in the hand, child will be able to reach out for it, take it to his mouth, all those. But the child may not be actually looking out for these objects to reach out for and take. So those are two early signs in the infancy which will suggest vision impairment. And later on, once the child starts walking, frequently bumping into objects, these children can have visual field defect. So if the child is looking ahead, he may bump at floor level obstacle. If the child is looking down, he may bump at obstacles at eye level. And the child will be very unsure of depth perception also. So many parents say that he may climb upstairs, but to climb downstairs, he takes a long time. He searches for the next feet and he has to place his leg down. And simple symptoms that children with CVI can have is difficulty in searching out and finding out a toy from a group of toys. So if there is a toy basket, the child will have difficulty. Although the toy may be direct in front of him, he may have difficulty in going and searching for it. And many of them can also have color preference. Color preference meaning they may preferentially look at red or yellow colored items compared to other items. And one more symptom that the parents say is they do not like visual novelty. They may keep looking at the same things again and again rather than preferring to look at new things. So these are some early symptoms suggestive of cerebral visual impairment, but definite screening, watching out for these vision improvement, watching out for these visual milestones and looking for visual acuity problems. These three things in a child who has risk factors, we can pick up CVI early.
Thank you. It's a wonderful answer. Sivaraman.
Sir, just to continue.
Solluங்க.
Madam, how do you manage stammering or stuttering? I'm deviating a little.
I have a case on that.
How do you manage, madam?
I have a case on that. Can I take it a bit later? I have a case.
Okay.
Yeah, on stammering.
Sivaraman.
Sir, doing an OAE, I think now even the government hospitals are doing, sir. It's being done everywhere. So I think it is not a big thing to do an OAE. We are doing routinely at Erode for all the babies. So it's just that you can ask someone to purchase it. It costs hardly around 3 lakhs. You can do it. Just to continue with the previous case, the same scenario, we have a child, 4-month-old child who has not attained a social smile yet. Otherwise, the antenatal, postnatal, all the histories are normal. Leena, madam, how would you want to approach now this child?
So
this 4-month-old child without a social smile at 4 months of age.
Correct.
No
so
social,
again, we need to, so any child with developmental delay, whether it is motor, speech or anything, we want to know whether it is isolated in that domain or is it a global. That's our first approach. So when you are talking about social smile, we are talking about, we need to make sure about, of course, the vision first. Okay, if the vision is normal or not, as Dr. Srinivas already said, the child social smile might be delayed if there's there's a vision problem. And then we are looking at whether is there a high risk factor? Was the child premature? Was there anything in the perinatal history which might put the child at high risk for developmental delays? And then, of course, we carry on with, there can be, a host of things. It can be an early symptom of global delay. It can be an early symptom of autism spectrum disorder. I think the most important thing that we don't forget is the vision in here.
Yes, madam. Correctly.
How long we can wait, madam? How long we can wait?
We don't wait. We never wait.
Okay.
Okay, never, ever, ever wait.
Okay.
So the reason why it is very important to pick up vision and hearing very early, because the sensory cortex, the neuroplasticity that we talk about, in the first 6 to 8 months, a lot of things are happening in these sensory cortex of vision and hearing. So if we miss out in this first 6 to 9 months, then we have lost the boat. The deficits are not going to be as, the final outcome is not going to be as good as what we would have picked up earlier. And that is the whole point of doing the universal hearing screening at or around birth, so that things can be rehabilitated before 6 months of age.
So the take-home message here.
Yeah, Raghavan, you go ahead.
Another common entity in vision problem especially is developmental visual maturation. There is a delayed visual maturation that can happen in some children where we start intervention, visual stimulation measures are started, and gradually the child starts having social smile. One more very common problem in affluent homes is overstimulation. So the child is left on the couch, child is given a lot of toys to play with, but there is no person to play along with the child. So poor social input also makes the child get distracted to the environmental things and less towards people. Their social smile may be slightly delayed. Again, after ruling out visual problems, after ruling out global developmental delay, if the child then started on visual stimulation, one of it is face-to-face. Parents are asked to take the child in hand, smile and talk to your child, cuddle your child often. It's a part of visual stimulation strategy. Keep the environment simple, keep the background quite simple, and the child will start having social smile as well. But vision problems definitely should be ruled out before thinking of autism and other causes.
The take-home message would be absence of social smile at 4 months could be you have to rule out a sensory. Could it be an early sign of autism, wherein a child is not reciprocating with the mother, child is keeps on excessively crying, even if the mother cuddles the child? Should we take it as an early sign of autism? To the Leena, madam.
No, it is an early sign, but we are not going to label it as such. Okay. So the labeling that this child has autism spectrum disorder happens much, much later. Early intervention and early stimulation has to start in any case, if there's a question mark, without labeling. And a diagnosis is not needed, or a label is not needed in our country, definitely, for starting early stimulation. In some of the Western countries where a lot of therapies are paid by insurance companies, they want some kind of a label. But in our country, we do not, we should just start with early stimulation activities for these children.
Raghav, you told mainly the treatable causes of isolated speech delay. Clearly, you told you have to rule out vitamin D, B12, and as well as iron deficiency. Madam, I want to know treatable causes of global developmental delay apart from hypothyroidism. Apart from hypothyroidism, any simple cause, maybe the GDD, maybe, as you told, maybe social deprivation. That is also one of the common.
Social deprivation, yes.
Are any
that
other
is one of the main ones. Second is, again, social deprivation can be because of excessive mobile use. Okay, so a lot of screen time, iron deficiencies, simple medical things can cause nutritional deficiencies, can cause something like a global delay. And neglect is one of the most important things.
And thyroid one should never miss.
Abuse, thyroid, abuse, neglect.
Okay.
And vitamin B12 deficiency also, sir. Very common, but obvious clinical signs will be there. Or just by doing a complete blood count, if the child has macrocytic anemia.
Lead poisoning. Yeah. So there is a host of these treatable conditions which can be looked at medically. With simple blood tests, we can treat all these things.
We come across a lot of children who complain of regression of speech. So could you just enumerate to us what would be the causes of regression of speech? Do you really see cases with autism who come to you with regression of speech.
No, so I think what usually usually what happens is if I get a 3-year-old child and parents say by 18 months he was saying mama, ma, papa, he was saying a few words, and then we gave him the vaccine and then he stopped talking. Okay, so that's the usual kind of history. So many parents give us. I think when you go into the depths of the history, you ask them whether the mama, papa was meaningful or was it just babbling. You come to know that it was mainly babbling. And when you start asking about the other social history, the social development of the child, the interaction, the play before 18 months of age, you know that there were deficits there. So true regression is, very uncommon in autism. There are very few cases with true regression. Most, I think, are a poor history or which has been given. Of course, when we are talking about regression and we are sure we're seeing videos of the child talking away, Landau-Kleffner is something which we always have to keep in mind, and an EEG might be warranted at that point.
Yeah, thank you, madam. See, like we can see very commonly, we don't see this thing of regression in autistic children, at least in our country. This we take it as wishful thinking, because most of the parents, this is called as wishful thinking. They presume that the child had been speaking.
So there is a lot of words which are coming. As I had said, there are a lot of words which are coming, which are repetitive words. The child has heard maybe on the screen ABCD or nursery rhymes, and he's saying it. So that's hearing and then saying, but hearing and understanding and saying is a different process altogether. So there might be a lot of repetitive speech which might have stopped after some time, but meaningful speech and that regressing, very uncommon in autism. Usually the speech has not developed as per the age.
And one more, the way we ask symptoms also. So when we ask history, when we ask language, we only ask, was the child able to say amma and appa? Rather, we should be rephrasing that as, was the child using amma and appa to get the attention of others? When ma'am was presenting, ma'am pointed out that one. The child should be using kinship words to get attention of others. The child should be using these words for communication. Autism is not just saying words. Children with autism may say words, but they may have never used it for communication. Even with parents who say that at 12 to 15 months, my child was saying many words, if you go back and ask them, what, did he ever use these words to grab your attention? They will say that by looking at us, he used to say, he was labeling people, but he may have never used these words to grab their attention. It is unlikely, it is very, very less likely for a child to have used some words for communication and then regress. In girls who have had such a regression, we should also keep in mind Rett's. And as ma'am said, epileptic encephalopathy like Landau-Kleffner definitely should be kept in mind. And very, very rarely, there are conditions like autoimmune encephalitis, which can also present as regression, cognitive decline associated with decline in other developmental domain. Child will be very sick, of course, with associated movement disorder, all those. That could also be a cause for sudden regression of speech where the child was using it for communicative purposes before.
So I think the first thing to determine is, was there true regression or not? Because then we have two paths. If there's true regression, we are going into a different direction. You have a lot of neurological causes. And if there is apparent regression, that's a different path altogether.
So we can just use this. We can use the simple things there, like I use it as a mnemonic, like OAE. We have to just ask first, A, then you observe, and then you execute it. So most of the time we ask them, the parents tell, yes, my child was doing it, but we never observe it. Like, for example, in an MChat, does your child point? Mother will always tell, yes, my child was pointing. My child was doing this. But I think the carry-home message here is ask, observe, and then you evaluate it. So I think this would one thing which we can take as.
I ask for a lot of videos from the home. So when a parent tells me that, okay, he's not doing it in front of you, okay, go back. We are not, go back, get me some videos so that I'm, I'm convinced that the child is doing all right, according to what the child should be doing. So videos from home are very, very useful for a lot of developmental programs.
Madam, before now, I little go to the little different spectrum above 5 years, and my child is not going well in the school. I want to know how you will differentiate a slow learner from LD, that is a specific learning disability. Slow learner versus SLD, or
Okay,
mild intellectual disability versus SLD.
no, I think, yeah. So when you talk about learning disabilities or dyslexias, yeah, usually we say IQ is normal or above normal. And the child is specifically failing to in the reading, writing, and mathematics area. And this child, as we say, has good motivation, good family background, good education system, intelligent child. So when you talk to him, he's a bright child, talkative child, responds well to questions. And then when you ask him to write a simple thing, he's not able to do that. What a child of his age can do. So I think that's where this thing. When we go back in the history, a slow learner would be, as this would be a global developmental delay to start off with, which might go into a slow learner or an intellectual disability category later on. So you'll have a full history of, the early developmental domains being very behind. And then when you're observing in the clinic, the child is not that communicative. There might be speech delays or other things. It's very obvious. And you do an assessment. If you do an assessment of IQ, the IQ will come in the slow learner or the intellectual disability category. On the other hand, a child with learning disability, they might have mild delays in speech, or they might have mild delays even in gross motor skills, but cognition is quite good. When you're talking to the child is bright. He answers everything correctly according to the age. His communication is fairly good. So, and then when you do the IQ assessment and the educational assessments, it becomes very obvious that the child's IQ is normal or above normal. But when you do the educational assessment, it falls much below what is expected of that age. Of course, the educational assessments and IQ assessments should not be done before 7 or 8 years of age. So the diagnosis of LD is after 8 years only. Suspicion, we can do it earlier. I have a case again. I had put a case again, and maybe I guess we won't have much time to do that.
No, another few minutes. We are going to
And
dyslexia
screening should not be done before a cognitive testing, sir. That also is very commonly done. There is a lot of mislabeling of a child with slow learning or intellectual disability as SLD because accommodations are quite different for these children. So it is imperative for us to go through a good history, good examination, and then suspicion and cognitive testing before going in for educational testing.
And fantastic point.
What is the role of all these nutritional supplements? We see a lot of drugs being prescribed, XYZ, a lot of casein diets or this diet, that diet. What do you like to comment? What is the thing you would like to tell this forum? Because most of the time,
in a nutshell, in one line, there is no evidence that it helps autism spectrum. So when there are omega-3 fatty acids, there's carnosine going on, there's loads and loads of brain tonics, and but none of these brain tonics are known to have any evidence basis to it. The problem is if when I see a prescription and I see that there are some brain tonics to be given and the parent has also been referred for therapy and interventions, the parent will leave the OPD and the first thing they will go and buy is this brain tonic, which might be costly, and they will want to try this brain tonic for 3 to 4 months or 6 months, and in that they are wasting the child's time. So I really urge let us not write the brain tonics lightly. Because that's the first thing that the parent will do, and we are going to miss out on the first few months of interventions.
Diet, madam. Diet. We see a lot of ADHD children put on.
So diet-wise, I think there is no evidence that sugar causes hyperactivity, but lot of anecdotal evidence from parents that if the child has something sugary or something sweet, he becomes hyper. At that time, it's low sugar diet is always a healthy diet anyway. So let us all be practical and pragmatic. Definitely in children with ADHD, chocolates, which will have a lot of caffeine, should be avoided. Artificial colors, artificial flavors, artificial preservatives should be avoided. In a child with autism spectrum disorder, there is a lot of hype about gluten-free, casein-free diet. And I think we need to do it case basis. It is not evidence-based that, every child of autism spectrum disorder will benefit from a gluten-free or casein-free diet. A good history which shows us a GI problems in a child with autism spectrum, we can evaluate for gluten sensitivity and then put it for that.
Thank you, ma'am.
Okay, Rama, anything to add?
American Academy of Pediatrics in their guidelines about pharmacology for parents, sir, about drugs and other medications in autism, they mention that systemic side effects need not be the only side effect. Cost burden for the family also should be considered as an adverse event for any therapeutic modality. So in that way, these
So it's a
medications
waste of money and waste of time.
yes. So
Both.
they mean
For the waste of money for the parents, waste of time for the child, the main thing.
yeah. So we should not say that these are innocuous.
Absolutely.
Madam, you can go ahead, madam, with your presentation.
Oh, there were 2 or 3, but then I think what one do you want me to do? Hyperactivity, or you want me to do the refer one?
And review. Yeah. Yes.
Let's do this refer and review. Let's see whether we can just go through some cases very quickly.
Yes.
You can see this?
Yes, ma'am.
I'll just put a slideshow. Okay, so in that 5 minutes of every consultation that you get with your pediatric patient, when a parent talks about a behavior or a developmental problem in the child, a lot of times you have those 5 minutes to make up your mind whether this is something to be worried about or and needs to be referred to somebody else, or is it some simple thing which you can reassure parents with. So let us just go through some case scenarios. Let's take this 4-year-old boy. Parents are extremely anxious and they come with a complaint that the child is stammering. And this had happened last year too. So in this case scenario, what are we going to do? Are we going to reassure? Are we going to refer? What are we going to do? Any thoughts?
If it is less than 4 years or 3 years, it's a physiological stammering. If it is more than 5 years, it is a pathological.
Okay, so let's go to the history. When you ask history and observations, the onset, the parent said this 4-year-old was just in the last 10 days. Similar episode happened last year. Developmentally bright child, talkative, no speech delay, family history, nothing. And in clinic, he has a few repetitions of word, but it's a comfortable child. So as Dr. Palani Raman sir rightly said, developmental disfluency, very common. Under 5 years of age, at least 5% of children are known to go through this developmental disfluency. However, if the history in this 4-year-old child was that it's been ongoing for 1 year on and off, and recently it has got a little bit worse. And when you see the child is a bright child, but had some early speech delay. There might be a family history of stuttering. And when you observe the child in the clinic, the child avoids talking, and you see a lot of these secondary behaviors where the child is avoiding eye contact. He's trying to get the words out of the mouth. Those kind of secondary behaviors are seen. And then that's when you're going to be worrying about stuttering. So it is not just the age. You're very right that developmental disfluency is very common. But if there's a family history, if there is a developmental speech delay, then we need to, and there are these secondary behaviors, we need to worry about long-term stuttering in this child. So what are we going to do for developmental disfluency? Review, reassure, review, or refer?
It's a review, madam.
Okay. So we have to first reassure, second review, advise what is to be done, and third review. So we have to reassure, advise, and review. Okay. While the child with stuttering, we have to advise, refer, and then review. And let me tell you what I mean by this. In a developmental disfluency child, when we are saying reassure, advise, and review, we are going to reassure that it's likely that the child will outgrow the symptoms. And you have to allay the anxiety of the parents, because more the anxious the parents get, worse they are going to pass on this anxiety to the child, and the stammering can get worse and will last for a longer time. After reassuring, we have to advise about what not to do. I'll come to that in a minute. After this advice, you're going to call them back in a couple of months' time to review the child. So we have to do all of those three. We have to reassure, advise, and then review. If a child has features of stuttering, like we talked about, then we are going to advise, and we might be telling the parents that these are associated with some anxiety, behavioral problems. There are some coexisting speech and language developmental disorders. It's been going on for more than a year. There is a possibility that it might go on for a while, and we need to do something. We have to again advise about what not to do, and maybe needs a referral further on. But also always call the child back for review after 3 months to make sure that whatever referral you have done is working in the way the parents want it, so that kind of allays the anxiety of the family. So what are the don'ts? What are we going to advise? We are going to advise in both cases, whether it is developmental disfluency or stammering or stuttering, do not rip. There are lots of don'ts in this case. Do not reprimand. The child is not doing it purposely. Do not tease or mimic. A lot of times, parents say, "Oh, you're talking like this," and they try to mimic the child, and that doesn't help the child. Do not rush them to speak. Do not interrupt when they are trying to speak. Do not break eye contact. Do not change facial expressions. Do not become very exasperated or frustrated that the child is stammering. And don't ask too many questions in a hurry. And very, very importantly, don't ask to repeat the word. So what happens is, if a child is stuck on a word ball, for example, I want to play with the ball. Parents say, now say ball again. Obviously, the child is able to say ball. It is not because the child is not able to say ball that the child is stammering. But then we are refocusing the child's attention on the stammer. What do we need to do? We need to maintain eye contact when the child is talking. You need to speak slowly yourself and patiently listen. What I usually say, if there are more than 4 repeats, supply the word. So if the child is saying b, more than 4 repeats, say, okay, ball, and continue the conversation. Do not ask to repeat the word. Take turns in talking and encourage and support him. So these are some of the do's and don'ts which I kind of tell them in the clinic. Does that answer the question?
Yes, ma'am.
Okay.
Madam, one doubt, madam. One doubt.
Yeah.
Keeping eye contact.
Yeah.
Is it good, or I'm a little skeptical about it?
So what happens? No, we should keep eye contact. So when I'm
looking at his face keenly, he will do it more, isn't it? No.
No. So it depends upon your facial. The child is looking at you. A child who knows that he's stammering is already quite anxious, and he's looking. If your face is smiling and you're looking at the child as if he's not doing anything wrong, that will decrease the anxiety.
Okay.
If you are looking at the child with eye contact, but you are making exasperated facial expressions,
yes.
That's not the eye contact that we are talking about.
Okay.
Smiling face with a good eye contact. Yeah.
Okay.
Let's come to the second scenario. Parents have brought 20-month-old child who's putting everything in his mouth. He's mouthing toys, he's mouthing shoes, he's mouthing mud. Normal or pathological? Normal or pathological?
20 months pathological.
20 months pathological. And what should we do, and when should we be concerned? So I'll just put it here. So mouthing is a phase where child explores. We know that, till 2 years of age, Piaget says that there's a sensory motor phase where child explores everything through his mouth. So it's normal till 1 year of age. Should decrease by 2 years and should disappear by 3 years. However, if there's a 20-month-old, you can ask the history, the onset, duration, and progress, whether it is getting better. So he was putting a lot more. Is it getting better? You have to look at the development. Reassure the child, parents, if it is developmentally on track. The rest of the development, if it's on track. But obviously, if mouthing is persistent or developmental issues are there, then we are thinking about pica, which is persistent eating of non-food substances, more than 1 month duration. We are going to ask about a developmental and the behavioral history. This can there can be nutritional deficiencies or neglect and abuse in the family. We also know that children with intellectual disability, autism, sensory seeking behaviors, this might be present. And this child needs to be referred to the appropriate people. We need to treat the underlying condition. And as you know, we usually do with pica, deworm, be aware of lead poisoning and treat the nutritional deficiencies if there are. Okay. Let's go to the third scenario. A 2-year-old boy, parental concerns are that he's keeping on repeating words and phrases that he has heard. Because parents have heard a lot about autism, that's what they're worried are, that is this a symptom of autism? What are we going to do?
Look for other things.
Absolutely. So reassure, review, and refer. First, we need to be aware ourselves that repetitive speech, repetition can be a common part of language development. It is seen in young toddlers who are just learning to talk. By age 2, most children will start mixing their own speech or utterances along with the repetitions that they hear. And by age 3, echolalia should be, that repetition should be minimum or no. So all repetition is not autism. We have to look for other things as well for autism. But a child who's less than 2 years, if he's repeating, if all else is normal, we can only reassure. This scenario, parental concerns, 4-year-old has just started writing, confuses between B and D, P and Q. Nothing significant in birth, development, family. No complaints from nursery school yet. Again, parents are highly worried that the child has dyslexia. So same thing again. Mirror imaging can be normally seen between 3 to 4 years of age as the children are learning to, beginning to learn alphabets. Gradually, it should improve and disappear by 7 years of age. So we need to just kind of reassure depending on other symptoms. So all mirror imaging is not dyslexia. It depends on the age of the child and whether the things are getting better. Simple advice about how to overlearn of alphabet. So can be given to a concerned parent. So for example, if a child is getting confused between B and D, usually I say, let him overlearn B, the way B looks. Let him only learn B and then D is the other one. Okay. Teaching in a playway method always helps. Again, of course, if it was an 8-year-old child and he's having this, then these are foundations for further academic learning. And this will be very, very concerning in an 8-year-old child, but not so much in a 4-year-old child. We have to be aware about at-risk children for dyslexia, as we were talking earlier. If there are perinatal problems, genetic, hereditary, early developmental concerns, the delayed gross motor, speech and language, fine motor problems may affect handwriting, difficulty in laces, poor concentration, poor coordination. All these are early developmental concerns which might be seen in a child with learning disability. Between 5 to 7 years of age, inability to put the alphabet or the sounds together. So the phonics, B says B and D says D. The child is unable to pick up in face of a bright, normal young child. In face of a bright child, otherwise, the child is unable to pick up this phonics, which his peer is able to pick up very easily. So dyslexia is likely when these difficulties are severe and they persist, or when several such difficulties are in a milder form. So I think what I'm trying to say here is, let us not throw diagnosis loosely, because those diagnoses and labels stick. Parents go on Google when you give a label or a diagnosis very loosely, and then they kind of go into their whole that depression, that grief cycle. You know, they might be go into denial, anger, depression, and all those things, and might end up going into the wrong direction. This is one of the last OPD scenario I have put. 4-year-old referred by school, where the child, the school's concern was that this 4-year-old is irritable in school most of the times. He doesn't pay attention. He doesn't follow instructions. And he goes off to sleep sometimes, and he sleeps through 2 hours as well in class. When I saw the child, history was normal, nothing in family history. Every early development was within normal limits, nothing there. In the clinic, he greeted me very well. This was what, I think 5 years old. Answered basic questions very relevantly, but he had slurred speech. He was drooling. And then he started becoming very irritable, became drowsy, and he slept off. Okay. And the history was, when we go back in the history, it was the parents had concerns about the child's behavior at around 18 months of age, that the child was stubborn, the child was headbanging. They went and met their pediatrician, who reassured them that it is temper tantrums and normal for age. However, parents continued to be worried, and so they went for a second opinion. And they met a psychiatrist. And to cut a long story short, in the span of 2 to 5 years of age, these were the medications the child was on. Different doses, multiple medications. And what we were seeing at 5 years were the side effects of these medications. Parents were counseled regarding behavioral handling. Medications were weaned off. School was cooperative. The child is doing very well academically and socially. So the lesson that I want to take home is, tantrums, we know that they are normal at 18 to 24 months of age, and sometimes it can be severe and difficult to manage. But if they are handled wrongly, they will last longer. So parents need to be taught handling, and practical solutions have to be given. So just saying that this is tantrum and it is normal, if it is causing a day-to-day problem for the child, unless we give them solutions, practical solutions to work at home, they will go again, doctor shopping or shopping on the social media. And they might end up, with some psychiatric disorder or label or some medication, which is highly inappropriate for a 2-year-old. So we need to be aware of the normal variations in developmental and behavioral milestones. So we can assure parents as needed. Because once we know what is normal, abnormal patterns of development are very easy to spot. All behaviors have to be correlated with the age of a child. So a child who is overactive at 2 years and a child who is hyperactive at 4 years, that behavior which is okay for 2 years, when we see it in a 4-year-old, that's where the concern starts. So all behaviors, secondly, should be correlated with the developmental age of the child. So when I say this, what I mean is, if a child who has global developmental delay, a child of 4 years of age, and his DQ is 50%, so he's working at the level of 2 years, his behavior is also going to be at the level of 2 years. He doesn't need an additional diagnosis of ADHD unless his behavior is worse than his developmental age. So all behaviors have to be correlated with not only the chronological age, but also the developmental age of the child. In all children, we have to reassure, advise, and review. Even if all is well, that is important that we do this. We go through this reassurance, giving some advice, and then calling them back for a review is very important for all parental concerns, because otherwise they will have their questions and they will find out different sources for their questions, which may not be appropriate. Thank you. Yeah.
Thank you. Thank you very much for such a common things, again, completely demystified. Again, to continue with the same thing, another one question is, madam, physiological hyperactivity versus ADHD.
Can I quickly say, do my next presentation, because it's I've written it very well in that. Can I just do this?
President sir, 10 minutes, 15 minutes?
Just give me 5 minutes.
Okay.
Let me just,
Okay. Yeah.
Because I wanted to, this is very important topic. Let me see where I have put it. Yeah. I'll not go through the entire this thing.
Okay.
But just this, some principles of behavior we know. It lies in the eyes of the beholder. It's a mix of nature and nurture. We know this, right? We talked about this. We need to know that all behaviors is a form of communication. So every behavior has a function. Okay. So this is what you are asking me. A 4-year-old, I put a case here, 4-year-old brought with viral fever. And what you see is he's all over the place in the clinic. He keeps on wanting attention. He's climbing, jumping loud and pulling down toys. And in this common scenario, we wonder what should be done. Okay. Because young children are going to be active. They are going to be impulsive. But when does a cute little boy becomes beyond naughty? and a pathological hyperactivity is what we have to identify in those few minutes. So hyperactivity, as you rightly said, is just a symptom. What we need to identify is this hyperactivity significant? One, and is it ADHD or and something else? Okay, so these are two questions that are going away in our mind. For that, we need to know what is normal activity level and what is normal attention span. So activity levels are in three stages. The first stage is exclusive attention, which is in infancy. So if you give an infant a toy or a rattle, we'll play with that for a very long time, giving exclusive attention to that rattle or even a box. The next stage is inclusive attention, where around 18 months to 2.5 years, everything in the child's environment will grab the child's attention and the child fleets from one activity to another. So this is called inclusive attention span. And the third stage of attention span is where the child is able to shift focus from inclusive attention to an exclusive attention. For example, in a classroom situation, during snack time, the child might be all over the place, but when the teacher comes, the child should be able to shift focus to what she is saying. And this shifting or the third stage is important for classroom learning. If that doesn't happen, that's where problems start creeping up in the classroom. Very important, what is normal attention span? Usually we say 3 minutes per year. So a child of 2 years, we expect a child to be able to focus for about 5 to 6 minutes. A 5-year-old child, 15 minutes. So if a 5-year-old child comes to you, the mother says he's able to do only his homework only for an hour, he doesn't sit more than an hour, you need to reassure her what is normal for that age. Okay. So this 4-year-old, again, when you are bringing, the first step should be, we should, if you know the family, you know that are there any risk factors for pathological hyperactivity? Because we know that ADHD has a biochemical and a genetic element. So a child who might be premature or low birth weight or any other family history or syndromes, you are aware about it, that might put the child for a risk factor for pathological hyperactivity. We need to have quick assessment whether there is anything in the history or examination which is simulating or exaggerating the behavioral symptoms. And there's this whole list of, nutritional deficiencies, thyroid problems, vision, hearing, we can never, sleep disorders can cause irritable child or hyperactive child. Screen time, we should never forget. And then how to determine if this child needs further assessments. So basically, what we are looking for is history of behavioral symptoms. How frequent are they? How long have they been doing? And how bad are they? And what we are looking for is the number and frequency is high as compared to other children of the same age. So if this 4-year-old child was a 2-year-old, we wouldn't be so bothered about that child climbing on things. But a 4-year-old, we expect the child to be a bit more calmer. So we might ask the parent a little bit more about the duration. How long? Is this something which the child does only when he gets excited in my clinic? Or is it something which is an ongoing thing? We're going to ask, is it something which the teachers have said anything about? Or again, are you worried at home? Is he hyperactive in the school? Are there any developmental issues? Because again, all these symptoms put a child for pathological hyperactivity. And is it affecting any of his daily activities, like in playing with children, studying at school, paying attention at school, and parental management at home? Is it affecting that? Then, you need to address that. And very quickly, I put this. This is something which, again, not comprehensive, something we can quickly look at in the OPD. You ask about symptoms, whether the child is hyperactive at home, at school, or both home and school. So if the mother says the child is very active, I'm finding it very difficult to manage at home, but there are no concerns from school, we have to look at whether, it's the screen time, the parenting, the boundaries, inconsistent parenting, what's happening in the family. If the mother says, oh, I don't have any problems managing this child at home, but I don't know why the school keeps complaining, we need to look at one ADHD, because the child might be focusing in one-to-one atmosphere at home, but in a group situation, the child may not be able to pay attention. Of course, learning issues like dyslexia, the child may not be able to pay attention. Vision, hearing, we never forget. If the mother's history that the child is hyperactive both at unmanageable at home and school. Just quick look at the development. If the problems with, there are some issues with development, language, learning, we are looking at lots of these neurodevelopmental issues. However, if the child's development is normal, he might just be a bright, overactive child. And how to differentiate between the pathological hyperactive and a bright overactive is, when you ask the history, the bright overactive child will always finish the task before moving on to the next, finish the task very quickly, while a child who has pathological hyperactivity leaves it unfinished and moves on to flits from one thing to another very quickly. So that is one of the crux kind of thing which you can ask the parent. Okay, let's quickly going back. If you feel that this hyperactive of this child is not pathologically significant, but if the behavioral issues are still concerning for the family, we are going to talk about basic management of screen, sleep, feeding, and counsel the parents and call them back, even if you are not worried. So I think it's very important that even if you are not worried, but if the family is worried about any behavioral development, after counseling, you're going to call them back in a few weeks to find out how the family is doing, because otherwise they will end up doctor shopping and going in the wrong direction. If, of course, if you feel there are significant concerns and you are going to refer ahead for detailed assessments, even then, in the meanwhile, some basic management and counseling should be happening with the parents. And what kind of basic management? How to handle hyperactivity? Remain calm. Not only the child, the parents have to remain calm. If the child is hyperactive and the mother is overreactive, it's going to go in the wrong way. Screen time, channelizing physical activity, firm and consistent handling. I use timers, so I can say, so your child is able to sit for say 2 minutes at a time for a given task without a screen. When you are doing a task with him, put a timer and put a timer of 2 minutes 5 seconds and gradually increase the timer. And let's make it a game that when the mobile timer goes off, we'll get up. So till the mobile time goes off, the child doesn't get up, and gradually increase the time. This will help in improving the sitting tolerance of the child. Improving attention span. Remember to get any child who's inattentive, get his eye contact, go down to their level before you give the instruction. Give short instructions, not many lines. Ask them to repeat back the instruction so that you know that they've heard and paid attention to the instruction. Give positive instructions. Very, very important. What this means is when a child is, say, jumping on the bed, a mother usually says, don't jump on the bed. The child will go and roll on the floor. The mother will say, don't roll on the floor. Then the child goes and bangs the table. The mother says, don't bang on the table. And what happens is, in this process, both the mother and the child are getting frustrated because the mother thinks that the child is not listening to her, while the child says things that I'm listening to her because she told me not to jump. I stopped jumping. So instead of giving a lot of negative instructions, don't do this. Giving one positive instructions, come here and sit on the table and do this, always helps the child to know what is the right behavior and what the child is expected to do. And then giving simple responsibilities in the house always helps the child to channelize his attention. Just last one case I'm going to put up. 9-year-old boy, parents brought for a second opinion to me because there was concerns about hyperactivity in school. The school referred to a psychologist who looked at the rating scales and diagnosed ADHD in the child and referred further for medications. Parents were worried about the side effects, so they came for a second opinion to me. To cut a long story short, while examining, this child had gross motor incoordination and calf muscle hypertrophy, and the child had Duchenne's muscular dystrophy. So I think sometimes medical and neurological conditions can be overlooked in the face of this overwhelming behavioral issues in a child. We have to be aware that there are certain conditions which may coexist with this behavioral and not forget to look for them. So yeah, thank you very much. Thank you for giving that extra time. I'm sorry I had to rush through this, but I wanted to get a few points across. Thank you.
Thank you, madam. Thank you. Thank you. Padani?
Yeah, Raghav, anything to add?
Nothing
I think
much.
it's still, shall we wind up? If
Yes.
there is a...
Madam, only one question. Now with the presence of plenty of infertility and IVF centers coming up and plenty of not natural babies coming out, unnatural babies coming out, whether do you find any difference between this natural thing and unnatural thing because in your 10 years and because Bob it have been already been there?
So
The
yeah, I
difference
do
in
find
parenting.
Yeah.
Before
Sorry,
the
carry on, yeah.
answers. Difference in parenting only it matters, not the parents. Okay, madam, please continue.
No, I do in the history. No, I do find that IVF baby. The history they always mention the proportion of IVF babies, but there's no evidence to link as such, unless of course there is a donor egg and a donor sperm, when we are not aware about the genetic issues. But as sir rightly said, it's the nature versus nurture, and the behavioral epigenetics, tells us that we can have in Bollywood we see twins separated at birth. One grows up in with a
As
inspector
villain.
and a police
Well,
becomes
hero.
a policeman, and other becomes a robber, and that's just the difference in the environment and the nurturing. So nurturing can manage can improve the nature of the child.
Madam, one question from the question and answer session.
Yeah.
Professor PRC wants to know whether any early intervention can lead to increase IQ. That is the only question left out.
Okay. So yes. Okay. So not yes in the sense really yes, but what I want to say is, if a lot of parents ask me about brain tonics, is there a brain tonic, something? And I think our neuroplasticity that we have in the first 3 years is the best brain tonic that we have. That's the most important thing that we have, which we can explain to the parents. That is, the first 3 years of life, the first 1,000 days are the most important for synaptic formation, and missing, interventions of stimulating a child in this first 1,000 days is the most important way to improve the child's development and outcome. There is a concept called serve and return. Okay, this serve and return concept says that more you interact with the child responds back like a ping pong ball, game. That is what improves the synapses, increases the number, and strengthens the synapses. Now, in a child with a screen, for example, there are so many advertisements about different apps to make baby Einsteins. Okay, that's a passive one. You cannot interact with the screen. So that serve and return theory will not work in a screen. So you need an actual human being who's interested in the child to play. So play is the best brain tonic for a child, interactive play.
Sivaraman, final closing comments. Sivaraman.
Mother is the best toy for the child.
All family members.
Yeah.
And the family members.
Yeah.
Yes. Yep. Very good discussion, pa. Super. Fantastic.
Concluding remarks,
Yes.
remarks with the president.
What to say? I am really flabbergasted by the way it was going on. Really, every month with the experts, we are learning a lot of points. Thank you, experts, both of you. Thank you, Dr. Palani, Dr. Sivaraman, for making this a very good, interesting session. Excellent. We had a very nice time today. Thank you. Thank you.
Thank you.
Thank you, sir.
Raghavan, any last message you want to tell for the practitioners?
Developmental surveillance can be easily done, and it is definitely feasible. Where there is a will, there is a way, sir. We should all adapt it, and we should all do it, sir. It is imperative.
Yes.
Madam, your message to the practitioners, madam.
Developmental surveillance, wherever possible, always developmental screening, whatever is available in our area, and do not let go, however trivial the parents' concerns are, address it. Because otherwise, there are many other people in our on the social media who are ever ready to address parents' concerns.
Influencers.
Influencers are there. Many influencers are there who will, and their parents will go in the wrong direction. And if you put the first step in the wrong direction, you end up going on that route.
Thank you very much, madam. Thank you very much, Raghavan, as well as Leena, madam. Really, it was a really wonderful session, and everything is in the YouTube. Everyone can again revise and again make them again clear all the doubts again. Once you think anything, we can again write to us. And Madam is also there in Bombay only, so we can easily approach. And Raghavan is there in Vellore, we can easily approach. And thank you one and all, Madam. Thank you very much for a wonderful session, Madam. Really,
Thank you both.
memorable session, Madam.
Thank you, sir. Thank you,
Thank you,
madam.
sir.
Thank you, Srinivasan, sir.
Thank you, sir.